Cool. We're going to start the field care audit. So everybody, welcome to the Medical Advisory Committee meeting section for the field care audits. Today is February 10th, 2015. All the cases presented today are from the NorCal region. We had some fun cases. I'll tell you, there were some probably some stressed providers because we had some really sick patients recently. So, case one. We have a 75-year-old young gentleman. They were dispatched and they arrived at scene at 15:09. They departed the scene at 15:21. Not bad. Good times. 12-minute scene time. They were dispatched code 3 to a private residence for chest pain along with fire. They were arrived at the private residence, EMS that is, greeted by fire rescue personnel who gave them a brief report, escorted EMS personnel to the patient's location in the living room. Upon arrival at the patient's side, they found a 75-year-old male lying supine on the living room couch in company of fire rescue. The patient also is on O2 already by nasal cannula. Pretty standard stuff. Fire reported the patient was complaining of chest pain and presenting with what appeared to be somewhat anxious upon their arrival. The patient, fire reported the patient took one of their own nitroglycerins with some decrease in the chest pain. Fire assisted with a second nitro. Pain went from a 9 out of 10 to a 10 out of 10. The patient was found alert, oriented, ×4, normal GCS, pink, warm, and dry, speaking softly, which is the baseline for the patient, per the patient. Patient complains of sudden onset of sharp chest pain while cracking walnuts. I wonder whether it would have been different had been a different nut, but we'll never know. Patient reported the pain started in his epigastrium, radiated up into his chest. Pretty good history of the radiation up into the chest. Makes you think more cardiac. Could be GERD, gastroesophageal reflux disease, but he's 75. You know, nitroglycerin relieves GERD. It's a smooth muscle relaxant. Patient reports an increase in pain with cough and deep palpation. So is that making us think this is less cardiac and more pleuritic maybe? I don't know. A certain percentage of patients who do have cardiac disease will present with palpable pain and pain upon deep inspiration. A certain percentage do. So the patient denied any recent trauma. No nausea or vomiting associated with this. No shortness of breath associated with this. Patient does have a recent cough with green sputum. Gotta love that green sputum. He denies any recent other illnesses, fevers or chills, and he's going to be transported for further evaluation. So, vital signs as noted, that we'll talk about that. The EKG, which will showed normal sinus rhythm, no acute ST segment changes, but with a right bundle branch block. So, does a right bundle branch block prohibit us from being able to tell whether our ST segment elevation consistent with the STEMI? Yes or no? Not a rhetorical question. Okay, there's deadly silence. So, no, it does not. It's the new onset left bundle that makes it difficult. You can do it with a left bundle, but it's a lot more difficult. So with new onset left bundles, you still think that this is a acute MI until proven otherwise. Patient went to the life support unit with no changes, transported code 2, sounds appropriate, given an aspirin with no change. You know, every chest pain chart that I've ever read said, you know, the aspirin's given, and I know you have to document whether there was change or not.
You don't have to.
Well, it just seems silly, no change. Well, yeah, there's going to be no change. You're giving it for the platelets, not for the pain effect. Well, you could write, though, tastes disgusting, patient grimaces. Patient got some more nitroglycerin with, again, a decrease from 7 out of 10 pain to a 6 out of 10 pain. But it shortly came back to 7 out of 10. Patient has a IV started in the left AC, no issues. Patient has a rather high blood glucose of 298, so he's not the most compliant diabetic patient. List of medications and allergy medications provided and transported with the patient. That's my pet peeve. Yes, indeed. You need to put it in your PCR. I'm sorry, I look at the meds when I review these, and it's a good habit. One of the things that used to drive me crazy in the ER, list given to nurse, and that list vanishes. It's as if it never existed. So, patient presented in the position of comfort. En route, they attempted another nitroglycerin. The pain did decrease it again to a 6 out of 10, but occasionally returned to 7 out of 10. En route, patient was pink, warm, and dry. They had him in the position of comfort. Excuse me. And he had on and off again increase in sharp pain. So I'm thinking maybe this is not cardiac. Patient arrives to the ED with the pain being 4 out of 10 and denied any other changes. So maybe this isn't cardiac. He's on lots of fun medications. A prazolam, so he's got some anxiety. He's on aspirin. A atorvastatin, so he's got elevated cholesterol. Cortisol, which is an antiarrhythmic also for high blood pressure. Cyanocobalamin, common name vitamin B12. Calciferol, so he's got some issues with calcium. He's only on glipizide and metformin, so he's not on any long-acting insulin. Omeprazole, so does have GERD, gastroesophageal reflux disease, and sertraline, which is an antidepressant. So he's had a stroke, behavioral, meaning he's got anxiety, hypertension, he's had a cardiac stent, and he has some depression. Mental status is normal for the patient. The neuro exam, eyes were reactive, lungs, pain, pressure was reproducible, clear breath sounds, abdomen, unremarkable, extremities, unremarkable. Vital signs all look pretty good. His last blood pressure at 15/55 is a little low, but he has had a fair amount of nitroglycerin, so that can lower your pressure. They did a 12-lead and ALS assessment, started the IV, and they did the blood glucose analysis. So far, pretty good. Nothing out of the ordinary. Again, aspirin unchanged, nitro improved, and the nitroglycerin at 1538, no change. So, what do you all think of this EKG? This EKG has several things that at least make me worried. So,
Any glass?
I'm sorry, what? What, Brooke?
I thought I think it'd be glasses. I'm having trouble focusing on my screen.
Oh, okay. Well, he does have a right bundle branch block. And you can see the rabbit ears in V1 and V2 and to a certain extent V3. He's got inverted T waves in V1 and V2. So that's usually a sign of ischemia. So is he having a STEMI? Maybe not, but he's having, I think, some ischemia going on. To really tell, you need an old EKG to see what it is. If you look in V4 and V5, you can see some ST segment depression, about 1 millimeter in both. So we're thinking maybe this is GERD. Well, looking at his EKG, I'm not so convinced. I would not say...
Septal problem, possibly.
He's got some sort of septal issue, right? Well, the V4 and the V5 are starting to go into the lateral leads.
Yeah.
but he could have some inferior changes. I would definitely want a set of enzymes on this guy, and I wouldn't necessarily send him home. So overall, what did you guys think of the documentation?
Excellent. I liked it.
Okay, good documentation. Quality of care, I think, was good. I don't really have any other issues or concerns. I think the care was appropriate. Overall impression, I think it was good patient care, good charting. I don't think there are any issues that are brought up that necessarily need to change protocol. I think the take-home points for this is somebody at his age, even though it may sound pleuritic, his EKG was not normal, and at least in my mind, somewhat ominous looking, particularly the flip T waves and the SE segment depression got my attention. Do I think he's having a STEMI? No. Do I think he is maybe infarcting? Possibly. He can be having a non-Q wave.
You can only tell that with the enzymes, the cardiac enzymes.
You could tell that with the enzymes. So you'd have to do serial, getting troponins. So case 2.
What was the heart rate on that EKG?
67. So that was not too bad. So here's another cute, good one. We have a 55-year-old woman with chest pain and difficulty in breathing. En route, 2124. Get to the patient's side at 2132. They're on scene for 13 minutes. They depart for the hospital, 2145. Code 3 return. They arrive to find the patient in bed, attended to by her husband. Interestingly enough, the patient's on home O2. To get home O2 from Medicare, your baseline oxygen levels have to be darn low. Although she's speaking in full sentences, we don't know whether she has a history of COPD or asthma. Why is she on O2 at home? Why is she hypoxic at baseline? Appears pale, warm, and dry. So patient reports was walking at home about 30 minutes ago when she began to have mid-sternal chest pain. Good history. Patient is described as, that should be gouging, but I chose to leave in the provider spelling. Pain was initially 10 out of 10, which radiated to the armpit. That kind of makes it a little more concerning. Pain is increased with palpation, 6 out of 10 upon arrival of EMS. She had difficulty in breathing with the initial onset. She was nauseated, again another sign, and she was sweating or diaphoretic. She's had prior episodes, but does not report this long a duration, is kind of the way I pieced together that sentence. She was seen at the hospital last week for a similar episode, but is unsure of her diagnosis. Not all that surprising, although I would think that if you were in the hospital, you'd kind of want to know why. At least I would. Patient is transferred to the gurney, placed on 6 liters per minute O2 via nasal cannula. Her SpO2 goes up and her color improves. Vital signs were assessed. Patient was hypotensive. The monitor showed a sinus tach at 112 with beats per minute. 12 lead shows a sinus tach again with a right bundle branch block. The EKG is transmitted to the hospital. So she's transported code 2. Now this was interesting, per hospital request. That really bugs me when people tell them what you should and should not return. It's really up to the provider. Now this is interesting. She must be a COPDer. I didn't get that specific a history, but her poor SpO2, she doesn't appear to be having any respiratory difficulty. She's probably normally a little smurfish looking.
That hemoglobin problem.
Yeah. Maybe she smokes too much.
Maybe she's from Kentucky.
Oh, that's a possibility.
Across the creek, right? There you go.
Head's atraumatic, neck is stable with no JVD or deviation. Back is normal, chest is fine. Now, interestingly enough, lung sounds are diminished with very slight expiratory wheezes. Well, maybe she was tight enough that she just couldn't hear everything. Abdomen soft, non-tender. Pelvis and extremities were fine. So, they started an IV, but they found later on that it infiltrated. Damn, I hate when that happens. They gave her aspirin. They gave her an albuterol handheld nebulizer, improved her oxygen saturation. They got rid of the infiltrated IV. I think appropriately let the hospital know that she was coming in, that she had a nebulizer, and I wouldn't necessarily said profound hypotension, but I don't get that excited about a blood pressure 106 over 79. Might I tell them to hold the nitroglycerin? Yeah. Do I think that's profound? Not so much. So she's still having pain, 6 out of 10. The difficulty in breathing has decreased. They get a saline lock and no further changes in the patient's condition. So they did lots of vitals, very nice. The only vital sign that got me a little concerned was the 61 over 32 at 21:51. Pulse rate was up at 114. She had the uniform 18 respiratory rate, and I don't know, maybe I'm old-fashioned, but do people think low O2 really should be watt liter per minute versus medium O2? Or am I being too picky?
That's what's on the image trend. It's either low, medium, or high, and that's what you see.
Ah, thank you for the interpretation.
And did you notice that the respirations never changed?
Oh, yes, I did.
After albuterol treatment, it didn't decrease or increase or anything.
No, even with the rest of the O2 change.
Yeah, I think they took the respiratory rate once and just said, okay, it's going to be 18. So they did 12 lead. That's kind of an interesting 12 lead again. EKG, monitor, IV access, saline lock, O2, handheld nebulizer, and aspirin. They kind of were going off of difficulty in breathing and chest pain. I don't know whether I would have given this woman nitrates with her blood pressure, so I'm not going to fault them for that. I would be a little leery or hesitant to give a nitrate to somebody who had a blood pressure of 80 over 55. So, this is a hard EKG to interpret because the baseline is wandering, exactly. I agree it's tachycardic. I agree that it's got, I don't think it's, I agree it's a bundle branch block looking, yeah, right there. So that much I do agree with. I really would love to see a good P wave to see whether she does have COPD. You know, if you look at V5 here, the P waves are kind of big. Yeah. So maybe she does have underlying pulmonary disease. I don't know. So I did like, you know, the 12 leads again. Right bundle branch block. Do I think she's having some ischemia? Maybe. She's really got a lot of non-specific ST segment and T-wave abnormalities. I would have liked if they could have gotten a second 12 lead for a better baseline.
Well, and she was hypoxic at 90, there's no ecstasy or anything associated with it.
Right.
Yeah.
So I'm thinking, yes.
This was at 2142 or 2143. Oh, can you go back? I don't.
vital sign.
So this must have been done in the house.
Yep.
Would have been probably a good thing to have a repeat vital when they stuck them in the back of the ambulance, where everything was quiet and less movement and stuff, to hopefully get a clearer
A clearer reading.
12 lead.
So I think the documentation was pretty good. I don't think I had any issues with the quality of care. I think there weren't really any other issues or concerns other than a better 12 lead. Overall impression, what do people think? I'm seeing some shrugs, okay, good. I don't think there's many, if any, protocol changes required. Teaching take-home points, I mean, the baseline 12 lead.
This appears to be a patient, doc, that's got lots of medical history and lots of medical issues, so it's hard to go with a single protocol as they kind of did a little bit of different stuff, which of course makes it difficult to make it a nice clean call for teaching.
No, I agree. I think, you know, I included this because I really liked the 12 lead, because it's a teaching point of try to get a better 12 lead. Right bundle branch block, you don't necessarily have to worry. You can tell if they're having a STEMI. So,
did they document within their the report what they did when they noticed the hypotension?
no, they did not, and they did not give fluids because that was not documented.
With a saline lock.
It was a saline lock.
Exactly. And her mentation too, it seems like, we didn't get a GCS off of this, but obviously her mentation was...
Her mentation was fine.
She was tolerating, it was what, 80, right?
81, yeah,
So she was
61.
obviously, it didn't concern them if
Yeah.
she's on, you know, all the wheels were
We
spinning.
don't have a weight on this patient. If this was a 90-pound female, that might not be an abnormal blood pressure for her.
Correct. I don't know whether she was large or small.
You don't have meds here listed either, so we don't know if she's on.
Right, there were no meds listed. That's the list given to nurse. Okay.
That's the thing I'd say about this documentation, though, is that it should have meds listed.
Mm-hmm. I agree.
The history.
Okay. Now this is a good case. I really like this one. So, fall in a 78-year-old male. At the patient at 12:26, in service at 12:44. So they're dispatched for a fall at a local bank. They arrive to find this 78-year-old gentleman who's awake, alert, appropriate, all four, sitting in a chair in the lobby with a bank worker and the patient's friend at their side. Per the staff at the bank, they stated the patient suffered a fall. Okay? So, per the bank, the patient was waiting in line and just all of a sudden fell backwards, striking his head on the floor. That's always disconcerting. Kind of ruins your day. States that the patient didn't have any loss of consciousness prior to or post the fall, and that they assisted him from the ground to the chair. Then they called 911. So far, so good. Upon making patient contact, patient stated that he did not know why EMS were there, and that he told them, the bank employees, not to call EMS. Patient states that he has no complaints whatsoever. He denies any associated head pain, neck pain, back pain, chest pain, or any discomfort whatsoever, shortness of breath, headache, blurred vision, dizziness, nausea, vomiting, or any other complaint, as he put it, whatsoever. So you all can kind of figure where this is going.
Everybody's been on them.
Exactly. Patient states that he feels fine and that he does not wish to go to the hospital, nor will he go to the hospital. Okay. Patient states that he has had this happen to him in the past, when he just falls to the ground for no reason. Might you want to figure out...
He's proving gravity.
Yeah, he is proving gravity. Might you want to figure out why this is happening? Patient...
75, he probably doesn't care.
Good point. So patient states that he can recall the entire incident and that he never had any type of loss of consciousness. Okay? So his exam, completely alert and oriented ×4. His HENT exam is negative except for the small abrasion to the back of his head where he fell on his head. Pupils are reactive. Skin signs, which is not an appropriate abbreviation, but won't mention that. Pink, warm, and dry. Trachea midline, no JVD. Chest walls fine. Lower extremities, lung sounds clear and equal bilaterally is what CAEB, I do believe, means. Abdomen soft, non-tender. Lower extremities, full range of motion with good capillary sensation, motor function. Back and neck, nothing, no trauma. Upper extremity, good range of motion again and good CSMs. However, they did note that the heart rate was initially 60, and then it changed to a, quote, very rapid rate, at which time I asked the patient, could I put him on the cardiac monitor? Surprisingly enough, he agreed. So, he was in VTAC. That will ruin your day. He is a rate of 230. That's probably why he's falling out. He intermittently goes into VTAC. Patient states several times that there is no way he was going to the hospital no matter what. Asked if he could do a 12 lead on him. He said that was fine, but I am not going anywhere with you. I obtained a 12 lead which showed elevation in several leads. 12 lead was transmitted. Both my partner and I urged him to go. He said no. We told him having problems with my heart. Left untreated, we were afraid that he could have serious complications up to, including death. Again, when you're trying to convince somebody his age may not be afraid of dying, but if you say you'll live and you can't wipe your own butt, that gets people's attention. So, we went on typo there. He said, well, that's fine if I'm going to die. I want to die at my home and not at the damn hospital. Has a very valid point there. So, they told a friend, please drive him to the hospital. He needs to be treated. And she said she would try to talk to him into going to the hospital. Patient stated he would sign an AMA form. They said releasing LSU crew of any liability. It never really happens, but it decreases the risk. Patient signed the form saying he understood all the possible risks. The one thing they didn't mention is, does he have capacity? That they should have mentioned. From what they said in their PCR, he probably does have capacity to make that decision. The friend signed as a witness. They spoke to the hospital and the nurse, and that the patient's heart rate was in VTAC and had ST segment elevation. The one thing they should have done is gotten the nurse or the doc and talked to the gentleman. No questions or orders. Last time he was trying to get the guy to come once again, and he said no. Patient and friend were both advised to call 911 again if they had any issues. They both agreed, and the patient got up, walked out the door on his own power, and got into their vehicle and left. Hopefully he wasn't driving. No further contact was made by EMS, and they said they were advised and clear. So here's the, he says he had hypertension, unknown blood pressure medication, reasonably okay vital signs except for the pulse rate of 112. So, that'll get your attention, ladies and gentlemen. Kind of sinus rhythm, and then all of a sudden, ooh,
Bada bing.
whoop, bada bang. So right here, where's my little arrow? It just suddenly changes. That's definitely VTAC. And
That's a good catch, too.
great catch. And look at this ST segment elevation here.
Yeah, wow.
You know, not that I'm psychic, but with that type of ST segment elevation, I don't think he woke up again after he went to sleep. I think he was having a big MI.
I think he's going to get his wish.
Want to die at home?
Happens to him all the time, though, Dan. On the VTAC, he gets up out of his garden and goes back inside.
Yeah, and there's a nice run of VT.
Well, if I was a medic, I would have been checking the obits the next couple of days to see what happened to the patient.
No kidding. And there he is again. I mean, he's having huge inferior changes.
He's one tough dude, this guy.
No
Really
kidding. And so, yeah, so he was in and out. Yeah, if I got that 12 lead, I wouldn't be too happy either. So I think the documentation was good.
Yeah.
Quality of care was good. Frustrating as hell for the medics and the providers. I don't think there are any other issues or concerns. Care was good. I think they could have documented at least that he had capacity. That's the only thing. And I think they did a good job though. Yeah.
At that point, what do you want for capacity? Because they've already said that he was alert, conscious, alert, and oriented times 4. Able to answer he was answering all their questions. So what more do you want for capacity? What verbiage are you looking for?
Patient appears to have decision-making capacity. Yeah, they said it indirectly. I mean, but I would say that he has decision-making capacity. Because you got to think about it, he fell down and hit his head. So is he suffering from a head injury? And I would have had him do, some simple action demonstrating that he's just not relying on his long-term memory. What's today's date? Well, that's not a good one because I can't ever remember that. But, who's this person with you? Why did you come to the bank? And there's something like that just to prove that his mentation is good.
Don't you think that very intelligent people can fake that they have the capacity to respond on their own? And I've seen it. That's why I'm saying it. I think it sounds like he may have gone through this routine before. I'm not going to the hospital. I'm not going to the hospital. If I'm going to die, I'm going to die at home. And so it's to the point of it's very difficult to measure how confident they are to make those.
It is. There's no clear answer.
Or did Curtis to you about David?
Say that again?
About what?
Nothing.
Oh.
Background noise.
Okay.
Background noise.
Case 4. This is entertaining too. Internal defibrillator, shocking. So they arrive at scene at 20:29. 20:27 they leave. Dispatch code 3 to the private residence for heart problems. They arrive to find this 44-year-old woman, semi-Fowler's, on her couch, complained that her internal defibrillator shocking her approximately 6 times prior to arrival. That will get your attention. Patient reports to recent placement of its AICD, automatic internal cardio defibrillator, in the last 2 weeks due to being in and out of VTAC rhythm and having to be converted in the ED. Now I know why she had her AICD. So she's pale, warm, dry, alert and oriented, nothing on the HET exam, no deformities, pupils wriggling around, reactive. Interestingly enough, she had a facial droop. No mention whether that's new or old initially. Trachea's midline, JVD, chest rise and fall fine, good tidal volume. Surgical scar healing where they put the defibrillator. And the patient reports being, quote, hot before she anticipates a delivered shock. So she's probably getting some arrhythmia that she's sensing, and then so does the AICD and goes boom. No chest pain, no shortness of breath. Reports lying on the couch for most of the day. Yeah, if I got buzzed multiple times, I think I'd be lying on the sofa too. Cardiac monitor shows sinus just before it changes to torsades de Pont, and a patient being shocked by her defibrillator. Patient will go lethargic but never totally unconscious before becoming alert and oriented again. She did complain of blurry vision after each shock, and the patient was shocked a total of 13 additional times during their contact. So, she was awake and appropriate throughout the entire contact. Abdomen is unremarkable, back's fine, pelvis, nothing. Good capillary refill, no trauma, no deformities, equal grips, good push-pulls. So, did she have a stroke or did she have a Bell's palsy? Interestingly enough, she has a dialysis shunt. So, she's got multiple medical problems. Put her on the gurney, en route to the hospital, did their ALS thing, patient exam, vital signs, cardiac monitor, 12 lead, IV access with poor vein access. They said it was difficult because every time she got shocked, her legs and arms would flail. Yeah, I can imagine. So they did an IO, and they're, I think, to be commended. And they applied oxygen. Hospital contacted, no questions, no orders. They thought about MAG, didn't give it. I think with their AICD going off, I wouldn't necessarily have given her MAG. Now, she's got interesting medications. Famotidine is an H2 blocker for her stomach. Fluoxetine is an antidepressant. Cardival is antihypertensive, beta blocker. She's on prednisone. Now, if you look at her past medical history, she has lupus, terrible disease. That's what's causing her liver failure, or kidney failure, and her conduction problems. Forgot what the laminar is. Simvastan's for cholesterol. Warfarin, because she's got a shunt, maybe because it was a stroke and she just has limited to the face, but that's unlikely. Benzapril is an antihypertensive, and sotalol is a beta blocker. So she's got stroke, dysrhythmia, lupus, AICD, and renal failure. Here are her blood pressures and vitals. Looks pretty good. They did the IO, oxygen. Lidocaine was not for her arrhythmia, but for pain, for the IO. So here's her strip. Interestingly enough, her P waves are somewhat peaked, almost biphasic in some of them. Particularly if you look at this one right here. So she's got some underlying conduction thing going on because of her lupus. There they are, there she is in torsades. And you can really see in this lead, oh, bummer. If you look on the bottom lead in lead 3, you can really see how it narrows down and then starts expanding out again.
That's a real good strip right there.
But that one?
I'm impressed that somebody actually got it on a strip.
Yeah, really, because that section right there is almost textbook for training.
Yes, it is.
Most of the time you look over and go, there it is, and it's too late.
Yeah, exactly.
No, I was.
Get it? No.
I was really excited. They did a great job. This is anybody's guess. This is Fusion Beats, VT. It's just ugly.
The proper treatment for this patient,
Diesel therapy.
diesel therapy.
She's already on 2 antiarrhythmics, the Cardival and the Sodawall. I don't know what else they're going to do other than put her on a 3rd nasty antiarrhythmic. And here's the baseline. Really hard to tell if you look at the bottom lead 3 whether that's a PVC embedded in there or not. I think it is.
I think it's bigeminy.
Well, I think that's what that is
Yeah,
also.
I think you're right. Because there's the sinus, the one sinus beat that's going into the
I think you're right, Dan.
unifocal ones.
I think it's unifocal
Yeah.
bigeminy. So documentation was very good. Care was good.
The care was good because they're only there 9 minutes or something, so they beat feet.
Well, I would.
Oh heavens, yeah, there's something bad's gonna happen real quick. We gotta
And,
go.
and you don't want it on your watch. I think the documentation was great. I'm really very excited that they captured it. It's pretty unusual.
Well, he planned ahead too when he got that IO, thinking no telling what's gonna happen. He went straight to that. That was a good call.
That was an excellent call. So, thank you for attending. Any questions?
Good one.